Welcome to Motivational Interviewing, the basics. Now we're going to move ahead and think about what motivational interviewing is, and, importantly, how it often is different from common approaches in patient care. According to Miller and Rolnick, motivational interviewing is a client-centered directive method for enhancing intrinsic motivation to change by exploring and resolving ambivalence. Now let's look at the spirit of motivational interviewing. This quote really underscores the spirit of motivational interviewing. The aim is to help your patients find their own compelling reasons for change. Like Pascal says, my personal reasons are far more motivating than what others tell me I should care about. Motivational interviewing, or MI, assumes that ambivalence or competing priorities are the principal obstacles to be overcome in triggering change. Once that has been accomplished, there may be a need for further interventions, such as planning and skill training. The specific strategies of MI are designed to elicit, clarify, and resolve ambivalence in a patient-centered and respectful counseling atmosphere. MI is a collaboration between patient and clinician, not an authoritarian positioning. Confrontation puts a patient on the defensive. It forces a reality that the person doesn't either see or admit to. It's the patient's task, not the clinician's, to articulate and resolve ambivalence. Ambivalence takes the form of a conflict between two courses of action, each of which has perceived benefits and costs. Many patients have never had the opportunity to express the often confusing, contradictory, and uniquely personal elements of this conflict. An example of this would be, if I stop smoking, I will feel better about myself, but I may also put on weight, which will make me feel unhappy and unattractive. It is the task of the clinician to build a therapeutic relationship that is more like a partnership. By honoring the patient's experiences, perceptions, and input, an atmosphere conducive to change is created. The clinician's task is to facilitate expression of both sides of the ambivalence impasse and guide the patient toward an acceptable resolution that triggers change. The clinician is directive in helping the patient to examine and resolve ambivalence. In MI, the resources and motivation for change are presumed to reside within the person. It is the clinician's job to evoke and bring forth the person's inner motivation to stimulate behavioral change. This style is one of eliciting from the person, not imparting, inserting, or imposing. This can be achieved by asking open-ended questions. MI is not education, which presumes that the clinician's role is to provide the requisite enlightenment because the patient lacks key knowledge, insight, or skills that are necessary for the change to occur. The clinician respects the patient's autonomy and freedom of choice and consequences regarding his or her own behavior. In MI, responsibility for change is left with the person. The clinician affirms the person's right and capacity for self-direction. This approach empowers the individual. Authoritative approaches, in contrast, take responsibility and power away from the patient, and the clinician becomes responsible for the change process. Being compassionate means having empathy, looking at the problem or issue from the person's point of view or experience. The desire to alleviate suffering and working to act in the best interest of the person are other important components of being compassionate with patients. While coercion, persuasion, constructive confrontation, or external contingencies, for example, the threatened loss of job or family, sometimes motivate people to change, they are not at all consistent with the spirit of motivational interviewing. MI relies on identifying and mobilizing the patient's intrinsic values and beliefs to stimulate behavior change. And as the slide says, MI takes practice, and it doesn't solve all problems. Now let's review some of the basic principles of motivational interviewing. As noted on the slide, MI is founded on 4 basic principles. Expressing empathy involves seeing the world through the patient's eyes. Thinking and feeling about things as the patient does enables you to share in the patient's experiences. Expression of empathy is critical to the MI approach. When patients feel they are understood, they are more able to open up about their experiences. Having patients share their experiences with you in depth allows you to assess when and where they need support, and what potential pitfalls may need attention during the change planning process. In short, the clinician's accurate understanding of the patient's experience facilitates change. Meta-analysis of therapy research supports that empathy predicts treatment outcomes consistently across different theoretical orientations and modalities. When we express empathy, we are reflecting back and understanding. Remember, understanding, accepting, and agreeing are not the same things. Empathy communicates acceptance, which, paradoxically, facilitates change. When accepted as they are, people seem to be freed to change. Empathy encourages a collaborative alliance, which also promotes change. When clinicians have accurate understanding, patients feel understood, are more likely to explore ambivalence, and are more likely to change. When people feel accurately understood, the need to explain or defend decreases. They are able to put their energy into personal exploration, which facilitates the change process. Expression of empathy also leads to an understanding of each person's unique perspective, feelings, and values, which make up the material we need to facilitate change. Empathy is a combination of the words you use and your nonverbal communication, so pay attention to how you look, sound, and respond. As highlighted here, a pretty wide variety of responses are commonly mistaken for empathy. Stay focused on understanding the problem or issue from the person's point of view. How did they experience the challenge? And in the same way, empathy is not the same as the behaviors listed on the slide. Pause and think about your most common and instinctive responses to patients. Are you empathic? Or are you reactive, giving advice? In summary, feeling conflicted or torn between two or more ways of thinking is pretty normal when behavioral health issues are involved. Managing medications, weight, blood pressure, substance use, and a long list of chronic illnesses can be challenging. What we want and what is best for us often collide. Expect ambivalence. At the same time, know that change is possible. The second main principle of MI is to develop discrepancy by exploring the important differences between how patients want their lives to be versus how they currently are, or differences between their deeply held values and their day-to-day behavior. Helping patients examine the discrepancies between their current behavior and valued goals, values, or self-views is pivotal to making changes. The third main principle is managing resistance, which can include making excuses, blaming others, minimizing importance or significance, challenging, using hostile language, both verbal and nonverbal, and ignoring. In general, patients who are resistant are usually not ready to change. The idea of rolling with resistance means that we acknowledge the person's perception or disagreement, and then work to reframe it. As before, we don't confront or disagree. Instead, we work to give feedback that is empathic, and at the same time might question or expand on the person's viewpoint. The last main principle of MI is to support self-efficacy, which means helping patients move toward change successfully and with confidence. In MI, the resources and motivation for change are presumed to reside within the person. The clinician's job is to find ways to evoke it, to call it forth, bring it into action. The righting reflex refers to the seemingly built-in desire of humans to set things right. When presented with a problem, someone else's problem, We have the tendency to offer solutions. When this instinct meets ambivalence, however, the person defends the status quo and argues against change. The more a person argues on behalf of one position, the more committed to it he or she becomes. We can literally talk ourselves into and out of things. On the flip side, the more we can elicit change statements from people, the more committed to change they become. Asking patients their reasons for doing or not doing something is often more productive than telling them what they should or should not do. When it comes to behavior change, the patient often knows the answer. Listen to what they have to say. A patient who has a part in the discussion is more likely to be motivated to do something about the issue. In the next part of the program, we'll identify the basic steps and core skills involved in motivational interviewing. Thanks to our funding agency for supporting this program.